Hello, and welcome to our listeners around the world. You're listening to the JAMA Rational Clinical Examination podcast. I am Dr. David Simel, JAMA Associate Editor and Professor Emeritus of Medicine at the Durham Veterans Affairs Medical Center and Duke University. In this podcast, we will be discussing screening and diagnosing alcohol use disorder. I'm joined today by Evan Wood, who is a professor of medicine and the Canada Research Chair in Addiction Medicine at the University of British Columbia in Vancouver. Dr. Wood is the lead author of the Rational Clinical Examination article on alcohol use disorder in the April 9th, 2024 edition of JAMA. Dr. Wood, thank you for joining us today.
Thank you so much.
Let's get right into it, and I'd like you to give us the case definition of alcohol use disorder.
Yeah, so we've gotten away from calling people addicts, and we've got away from talking about alcohol addiction to where we now talk about alcohol use disorder, which is based on the Diagnostic and Statistical Manual 5th edition, which involves a threshold criteria. Patients must have clinically significant impairment or distress secondary to their alcohol use. And then we grade alcohol use disorder as mild, moderate, or severe based on the number of 11 specific criteria. So if an individual has 2 to 3 criteria positive, we call that mild alcohol use disorder. 4 to 5 would be moderate, and 6 or greater would be severe alcohol use disorder. And it's worth probably pointing out that only severe alcohol use disorder, many experts would say, is consistent with what people think of when they think about alcohol addiction, whereas mild alcohol use disorder is something we used to call alcohol abuse under the DSM-4.
So it sounds like from your description that alcohol use disorder is defined by the consequences of excess alcohol use and not excess alcohol use itself.
Yeah, that's a really important distinction. So the physiologic effects of alcohol, like withdrawal or tolerance to alcohol, craving for alcohol, are also part of the DSM-5, but nowhere in those 11 criteria is a measure of heavy alcohol use. By definition, then, you could be a heavy alcohol user but not have alcohol use disorder if you don't have clinically significant impairment or distress from your alcohol use. You might still have health harms, but you wouldn't necessarily have an alcohol use disorder.
Can you give me an example of some of the features of mild alcohol use disorder?
Yeah, so it's really just a minimum of 2 of those criteria. And I sometimes give the example to my addiction medicine fellows that I'm working with that it is a low bar. You know, if you have had a dry January and you've kind of struggled to not use alcohol for a month as part of a New Year's resolution, and you look in the fridge and you kind of crave, that nice cold beer that's sitting there, technically, if you had clinically significant impairment or distress, that would be a mild alcohol use disorder. So just really want to make the point that the criteria to meet the definition is quite low, and that's been controversial in some respects, but it could be anything. It could be trouble with work, it could be health harms, it could be trouble with your sleep or anxiety from drinking. The 11 criteria are pretty diverse.
So based on these new criteria in DSM-5, how common is alcohol use disorder that's mild or worse?
Yeah, so about 60% of adults in the US consume alcohol. And I generally tell trainees that a rule of thumb is about 1 in 10 people will have an alcohol use disorder, at least mild, but it depends on age. For people that are in that sort of young, really young adulthood, adolescence from 12 to 17, it's probably with some rounding closer to 5%. Whereas in the heavy drinking years, in the sort of 18 to 25, it's closer to 15%. And then when you get into adulthood over age 25, it's closer to 10%. And men tend to have alcohol use disorder at a slightly higher prevalence than women, more like 12% when all comers are considered, whereas it's about 9% among women. So a general rule of thumb is about 1 in 10, I think.
A 15% number in adolescents and young adults sounds like a big number.
Yeah, and that's why it's important to note that this low threshold to diagnose alcohol use disorder is important to understand, and why the definition is to some extent controversial, because we used to call that alcohol abuse under DSM-4, whereas now it would be called a mental disorder, whereas many people would say, well, college students are consuming excessive alcohol and maybe missing some classes and having some other consequences, might not actually have a mental disorder. So you need to bring some nuance to this diagnosis.
With the prevalence being that high, who should be screened for alcohol use disorder? Is it everyone? And which screening test should you use?
Yeah, so important to acknowledge that in certain environments, like in the emergency department, people coming in, young adults with trauma, someone coming in with a laceration and smelling like alcohol, the prevalence of an alcohol use disorder would be exceedingly high, 30 to 40%. But then you'll have people who might have very severe alcohol use disorder who don't exhibit any complaints. They don't actually have good insight, so they're not there seeking help, and they might not have any symptoms or signs. And so the US Preventative Services Task Force has recommended, going back to 2018, that all adults 18 and older should be screened for alcohol problems.
And what screening test do they recommend?
There's a lot of energy that's gone into different screening tests. And so there aren't clear recommendations around what should be used because in different age groups and different special populations, there's a lot of different tests that have been employed. Certainly, our article identified that the NIAAA, one of the US National Institutes of Health, has a screening guide for youth that looks like it's quite helpful. And then the World Health Organization has developed something called the Alcohol Use Disorders Identification Test, which by far is the most studied screening tool. And that looks like it can be quite useful in lots of different populations.
Tell us a little bit about the components of the audit tool.
Yeah, so the audit is a 10-question brief questionnaire. It only takes about 2 minutes to self-administer, and it's open access, so it's a really nice tool. It's sort of a Likert scale from 1 to 4 for those 10 questions. So it's scored out of 40. And yeah, the first 3 questions are about alcohol consumption. And then the remaining 7 questions are about consequences of alcohol use. So things like alcohol attributable blackouts or injuries. And we found that the threshold of 8 or more on the audit was really useful for increasing the likelihood of an alcohol use disorder. Whereas if an individual scored less than 8, then that was helpful for reducing the likelihood.
Is the audit useful in all settings and for all patients, or is it only certain populations where it's most useful?
Yeah, that's the important thing to acknowledge as well, and which the article identified is that there's certain populations where there may not be an alcohol use disorder, but there's still important education to be offered or clinical intervention in some cases. So obviously in pregnant persons, we want to identify any alcohol use and educate patients about the risks of fetal alcohol syndrome. In young people, there can be considerable risk of injuries with excessive alcohol use and looking to screen in those populations. And the audit looks like it's useful, though different thresholds. There's a limited amount of research in pregnant persons, and an audit with a threshold of 4 looked like it was useful. And then there's something called the Audit C, or the audit consumption, which is an abbreviated screening tool that just looks at the 3 alcohol consumption measures. And that looks like it's useful in some of those special populations. But the drawback is that the Audit C doesn't appear to be particularly useful for alcohol use disorder. So it looks like the audit is probably the best tool, and it's been studied in a range of populations and looks like it's effective in most populations.
Well, in your article, which was part of the Rational Clinical Examination series, you also address the issue of special populations such as adolescents and young adults, persons who are pregnant, and persons older than age 65, where they may not meet the criteria for alcohol use disorder, but they may be problem drinkers. Can you tell us about problem drinking and how you screen for that in these special populations?
Yeah, and that's really what I was alluding to there, and maybe jump the gun a little bit. This is a challenging issue in that there's so much heterogeneity in the literature and just international definitions for heavy alcohol use. So the NIAAA defines heavy alcohol use in men as more than 5 drinks on any one occasion or more than 15 drinks per week. In women, it's more than 4 drinks on one occasion or 8 drinks per week. And I'll share with you that in Canada, we have a similar historically definition of low risk drinking being below those thresholds, whereas we have new lower risk alcohol guidelines that say any more than 2 drinks per week is high risk drinking. So there's a lot of heterogeneity there. And we really had to grapple with that in the article. But we did show that this audit C, this audit that's just the first 3 questions of the 10-question audit. Looks like it's useful for identifying high-risk drinking according to different definitions. But again, the limitation of the audit C is that it's not particularly useful for alcohol use disorder. So from my personal perspective, in an individual who's pregnant, you probably don't need a screening tool. You could just jump right into questions about alcohol, although the audit C would provide some structure for that. For elderly individuals, the audit C looks like it's useful. For young people, the audit C looks like it's helpful. But the difference between 3 and 10 questions, particularly for a self-administered questionnaire, it may make more sense to just use the full audit.
So, problem drinking then is based on the amount of alcohol you drink before you develop the consequences of alcohol use disorder. Do I have that right?
In some individuals, that would be true, but then there's a lot of overlap. So, as I said, the definition of a mild alcohol use disorder is a very low threshold. And so there'd be lots of people who use excessive alcohol that would meet that criteria, but some who would not. And there's just so much heterogeneity in these definitions. There's definitions of binge drinking based on how much alcohol people use that gets used oftentimes in college students as definitions of high risk drinking. In other instances, as you say, it's based on the amount of alcohol being used. And in certain populations like pregnant persons, there's no question that it's important that any amount of alcohol is identified. Whereas if you were to say to me, what's the best screening test or what's the best definition of heavy alcohol use in young people, I'd point you to the article and say, well, it's a bit of a dog's breakfast for how international investigators have defined high risk drinking in young people, because there's no unified definition, which makes it quite problematic.
Are persons who are identified as problem drinkers at risk for developing the consequences of alcohol use to the point where they'd be diagnosed with alcohol use disorder?
Yeah, that's an important question, because I think the majority of people who use alcohol do not have an alcohol use disorder. But if they use alcohol excessively, they still, in comparison to people who don't use alcohol at a populational level, are at elevated risk of certain cancers, elevated risk of, end organ effects like developing hypertension or liver problems secondary to their alcohol use. So there's a considerable degree of overlap between excessive alcohol use and alcohol use disorder. But you can certainly have excessive alcohol use without clinically significant impairment or distress, and, be at increased risk of health harms, even in the absence of an alcohol use disorder.
Norms for drinking vary quite significantly around the world. And I'd like to hear a little bit about how the prevalence of problem drinking is affected by societal norms.
Yeah, that's a really interesting topic, and it's societal norms and probably also regulatory policies. So, the price of alcohol, the density of alcohol outlets that sell alcohol, the hours of operation of alcohol outlets, those can all have an impact on norms. And then there's cultural norms as well, and cultural norms in different environments like college campuses or different environments where excessive alcohol use is quite common. And those drive international differences. And probably the UK and certain European countries, similar to Canada and the US, have high rates of alcohol use and alcohol use disorder. And other jurisdictions where there's more controls on alcohol availability, or there's cultural norms that have evolved around less alcohol use, then you would see much less use of alcohol. And this isn't an insignificant problem. We quote a study from, I think, JAMA Network Open in the article, which showed that I think 1 in 5 deaths in people aged 25 to 45 are attributable to alcohol in the United States. So this is a huge burden of disease secondary to this, which speaks to the importance of screening, because studies also show that, at least in the United States and Canada, routine screening for alcohol use disorder is not the norm.
It occurs to me that there's a very basic question that maybe I should have asked earlier, and that is, what is a standard drink?
There's a lot of variability. In the United States, it's 15 grams of alcohol in a standard drink. So that's one beer that's a traditional 5% beer, or a glass of wine, though that depends on the size of the glass of wine, or 1.5 ounce of spirits would be a standard drink, or that 15 grams. In Canada, I think it's 14 grams of alcohol is a standard drink. And there's studies showing just how much variability there is in that definition.
Are people good at estimating how much they drink?
Yeah, that's a good question, because I think it's not just about estimation, but it's also about stigma and concerns with sharing information related to alcohol use with healthcare providers. And so that's sometimes where a self-administered questionnaire before someone comes and sees the clinician, or, really trying to normalize use of alcohol and make things more comfortable for people to disclose. And that's reflected in some of the screening questionnaires. Actually, the NIAAA Youth Guide suggests asking really young adults in that sort of 12 to 14 age range first, how many of your peers use alcohol? And then the second question is, how many times in the last year have you had even a sip of alcohol? Just to sort of make it easier for those really young people, probably to help them to understand that they're not going to be penalized or get in trouble by volunteering alcohol use to their physician. So, it's important that oftentimes people will minimize, or just by virtue of the fact of using alcohol and how using a few drinks can lead people to use more drinks, that they may actually not have a really clear understanding of how much alcohol they're actually using on a given week, until maybe they're taking their empties out to the trash or whatever it may be, when they're like, oh, geez, I didn't realize I had this many drinks. So it's important to pause there and understand what a standard drink is, and to be able to have those conversations in a way that people feel like they can really pause and think about how much they've been drinking, and ideally disclose as accurately as possible.
So what you're suggesting there for the teenager and adolescent is not using the Audit C, but using the NIAA screening test, which is pretty simplistic and just gets at the question of how many drinks you've had or a friend has had. Is that right?
Yeah, for the very young age groups, it suggests asking first how many of your friends drink, to just open up the conversation, and I guess a non-scary way for a very young person. But yeah, the NIAAA guide is very straightforward, because essentially it gets at how many times have you had any alcohol, how many days have you had any alcohol in the last year, and then there's age-specific thresholds to define a young person as low, moderate, or high risk. And those are sometimes hard to memorize for some clinicians. Certainly it would be for me, but the youth guide, which is available online, has a nice figure, and you could just, point on that chart based on how old someone is and how many drinks they've had, whether they're low, moderate, or high risk. And we showed quite, I think, elegantly in our article, the serial likelihood ratio of how the risk goes up between moderate and high risk within those number of drinking days in the last year thresholds.
Well, are there any other issues about screening or diagnosis of alcohol use disorder or problem drinking that you'd like to share with our listeners?
I think the things to just, hit home would be the very low threshold for a diagnosis of alcohol use disorder, and that really there's guideline directed interventions between mild, moderate, and severe. Somebody that has a mild alcohol use disorder, we probably should not be reaching for the prescription pad, but more doing some educational interventions and support and follow up around safer drinking levels. And then I think something that's rapidly evolving, and that's reflected in the article, and why we didn't spend a lot of time focused on high risk drinking, is that those definitions are evolving. And as I said, in Canada now, if you have 3 drinks per week, which seems like historically a very low amount, that's beyond the low risk drinking guidelines. And that guideline does show quite nicely how quite exponentially above 3 drinks per week, you start to see certain types of cancers or risks of injury or cirrhosis and other things. So I think this is a moving target. And for people that don't have an alcohol use disorder but are screened positive as drinking a fair amount, I think clinicians should be aware that this historical notion that there was probably cardioprotective effects of alcohol have kind of been disproven. Whereas if you're drinking a few drinks every day, you are putting yourself at elevated risk of certain cancers and other harms from that. So important things for clinicians to know, even when people screen negative, that it's still worth having that conversation about the harms of alcohol.
Thank you, Dr. Wood, for joining us today. I am Dr. David Simel, and we have been talking about alcohol use disorder. You can find a link to the article in this episode's description. This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at JAMAnetworkaudio.com or search for JAMA Network wherever you get your podcast. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.